Hey everyone, I hope you're having a wonderful spring. In the spirit of renewal, I wanted to share something new that we've been working on. It's called the Nocturnus Plus, our new subscriber-only feed. With a subscription, you'll get access to the Nocturnus After Hours, a monthly bonus series featuring original conversations between me and our executive producer, Allie Block, along with discounts on our new merch and access to all of our episodes in one place. To give you a taste of what it's like, here's a clip from our very first After Hours episode, where Allie and I talk about the ups and downs of being the doctors in our own families.
It was my first experience where a healthcare provider was sort of using lines on me that I knew. So the biggest thing was he was trying to transfer my dad out of the neuro ICU. And I was trying to argue that he was not ready to go to the floor. And I'm sure you're very familiar with this line. This ICU doc said what we say to patients in the hospital all the time, which is, it's really much safer for your dad to be somewhere else. He could get an infection. He could get a DVT. And I was just like, don't pull that with me. I know those lines.
That's the Nocturnus After Hours. We're really excited to see how this series evolves. It's been really fun so far, and would love to hear your ideas, questions, and suggestions along the way. If you want to join us in this new corner of our community, take a visit to thenocturnus.org/plus. Subscriptions start at just $10 a month. And now, on to today's episode.
Every episode of Trade-Offs is grounded in rigorous research.
The findings of this paper indicate
Thoughtful conversations.
A lot of the anger, while real, is somewhat misplaced.
And insights into what the latest in health policy means for you.
Hey, we're spending hundreds of billions of dollars. What are we getting for it?
We tell stories that cut through the noise, uncovering the data and personal stories that help you understand the stakes to healthcare's toughest choices. Subscribe to Trade-Offs wherever you get your podcasts.
At the Nocturnus, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
This is the Nocturnus. I'm Emily Silverman. Today's episode features Solange Madriz, a public health professional whose work has focused on maternal health, global health, and childbirth emergencies. For years, Solange traveled to rural Guatemala to help lead a low-cost simulation training program for birth attendants and clinic staff. Instead of expensive mannequins and high-tech simulation labs, they used whatever they had: fake blood, fabric placentas, baby dolls, improvised props, and one another's bodies. The goal was to help teams practice for obstetric emergencies, like postpartum hemorrhage, preeclampsia, and newborn distress, and to think through not only the clinical response, but also the realities of working in under-resourced settings. Then, during the pandemic, after the birth of her first child, Solange developed severe postpartum preeclampsia and found herself in a situation no amount of training or simulation could fully prepare her for. In our conversation, we talk about her path to public health, what she learned from working alongside birth providers in rural Guatemala, and what it was like to go from teaching emergency response to depending on it. But first, here's a clip from Solange's live story.
Another contraction! It hurts! Breathe. It's 2015. Believe it or not, as part of my job description, I was asked to reenact giving birth. Essentially, I have to fake birth as part of my job. And not the pretty births that you see in the movies. I had to reenact sepsis, preeclampsia, eclampsia, cardiomyositis, postpartum hemorrhage. Sometimes, not only I had to be the mom with problems, sometimes I had to pretend the baby was also having problems, such as being born and not being able to breathe, being born and being floppy, being born or being stuck on my pelvis. Again, this is 2015, and this job took me to the Western Highlands of Guatemala.
I am sitting here with Solange Madriz. Solange, thank you so much for coming on the show.
Thank you. Thank you for inviting me. It's a pleasure to be here.
So, Solange, what was it like to stand on stage and tell your story at the event?
I was so excited to tell it, but of course, it was the first time that I was going to talk about not something that it was professional, but something more personal. And I've done lots of sharing personal stuff. I'm usually a pretty open book. But the difference was like this time, it was with all the people in my office, higher ups and new people that I haven't met, even though I've been working at UCSF for 15 years. So they felt a little bit nerve-wracking to share that aspect of my life with a wider audience.
And how was the story received?
I think that people liked it. You know, when you are talking, I usually get on the zone. You're not really thinking so much on how it's landing on them. But then afterwards, like, oh yeah, they were laughing and then this and that. And it was reassuring that a lot of people approach me and say, like, Solange, you made us laugh. You made us cry. You made us, in one talk, a lot of things. And you made us travel to Guatemala with you. So I was happy at the end.
Amazing. Well, this show often will have doctors and nurses and medical students and residents and other types of clinicians. And it's not every day that we get a public health worker on the show. So I would love to hear a bit about what brought you to public health work and just a little bit about your arc through your career in public health.
Yeah, thank you. Thank you. I like that question. And it's a story I like to tell to students, in particular students from other countries. I think public health in the United States, it's been established. People know what it is. They can differentiate it from medicine. But in my home country, Venezuela, if you want to do anything related to health, you have to be a doctor. And when I was growing up and decided what I was going to do for college, what I was going to study, I knew that I liked health-related issues, but I also knew that I did not want to be a doctor. I did not want to be like looking at patients. My questions are the things that I was more interested in, or broader, like why Venezuela doesn't have access to the HPV vaccine that protects almost 90% of cervical cancers. And so I decided to study international studies. Then I decided to apply for graduate programs in the United States, and I came to San Francisco with a scholarship. And when I was here, I think it was part of like me leaving my country and understanding and exploring more my positionality that I started writing about international problems, but they all were related to impacts to health. So I would write things such as the impact of oil extraction in the Amazon rainforest on indigenous people. And then I got excited about understanding the impact of the North America Free Trade Agreement on the nutrition and on the lifestyle of Mexicans. And that was actually my dissertation. And by doing this, I started like really learning more about diseases, health problems. And I started like really talking to people like, oh, you know this and about this, and talking about the things that I was learning, until one day, actually, my sister said, you not only like health, you're obsessed with it. Like, why are you always talking? You're in parties, you're like a nerd talking to people about these things. I think you're in the wrong path. Like, you're not international studies. I think you're something more specific. And then other people listening to me would also say, like, oh, yeah, you're interested in health, but why didn't you study public health? I'm like, public health? What is that? So it was a very long journey. And then I found not only public health, but then global health, which is international studies, nursing, like having a baby. So it's health issues that transcend borders. And not only that are unique to many countries, but also the way that you approach them require more disciplines. It's not only like having access to health. Like, you need to understand, like, there are many other variables that affect health. And so I went on and I studied that, and it changed my life. So I did a master's degree in global health at UCSF in 2011. And I never left. I've been there ever since.
And you started to get interested in pregnancy, OBGYN, childbirth, specifically how to deal with childbirth emergencies in low resource settings. So tell us about that program, that educational program that you were involved in. I think you said it was in Guatemala.
Yes.
Tell us about that program.
Yeah, so it was one of the situations in which you are at the right place at the right moment. It was shortly after I graduated from the master's degree, and I've been doing more like office-related activities. So I was doing public health, but more research, like managing grants, overseeing deliverables of work that other researchers were doing. And then somebody approached and said, Solange, I need to leave this project, and I think you will be the perfect candidate to replace me. And I said, where is it? And she said, Guatemala. It involves a lot of traveling. And back then I had all the flexibility, all the time in the world to travel. And then I didn't think twice. I said yes. And it was really a beautiful program that not only changed the way that I approach education. It was the first time I was deployed into a country to oversee the implementation of a training program.
So this wasn't like in the city, right? This was in more rural areas. Like, bring us into the physical environment and the landscape. I know you mentioned that a lot of the people there did not speak Spanish. Of course, they spoke indigenous language. And I imagine it was a beautiful place. So tell us about where you were located and kind of the patient population.
Yeah, the places where I was, they were very remote. To start with, I had to land in Guatemala City, but then travel for several hours. They were in two big states of the country. One was Huehuetenango, and the second one was Alta Verapaz. And they are primarily indigenous populations, rural, and lots of greenery everywhere. And this part of the world, they use a lot of wood to cook. And so there's this scent of wood burning that to this day it reminds me to Guatemala. Like, when I smell like wood burning, it's like I'm traveling. That's Guatemala. And very clear skies. And I'm Venezuelan, and so in Venezuela, there are not usually a lot of indigenous population. And so that was one of the striking things for me, and to understand, this is not like a group of people. There's a lot of people. So a lot of times I felt that I was in a nation within another bigger nation. Yeah, and then it also struck me that population was very young, very active. A lot of in these villages, people moving around, but also at night or when the sun was going down, it stopped. The life was really around the sun. And I think a lot of things were traditional, women still wear traditional outfits, very colorful, long hair, braided. I would see a lot of women holding their babies in their back. And people were always hustling, doing things, multiple things at the same time. I remember seeing women with the babies in the back, and then doing chores around the homes, or going and with other kids, holding hands with other kids. And then with grocery bags, there was a lot of things happening even though there were small villages, but a lot of movement. But again, everything revolving around when there was sun.
And where did the women give birth? Was it a clinic? Was it a hospital? Was it a birthing center? What was that setup like?
When I was part of this project, and one of the goals of the project was to incentivize women to give birth in the clinic. Traditionally, in these two states, the majority of the women, I don't have the current statistics, but they used to give birth at home with traditional birth attendants. Traditional birth attendants are women without a formal training to deliver babies, but they inherited their skills from their predecessors. And the traditional birth attendants were not only women who attended women during birth, but they were also leaders in their community. So they're very well respected, trusted. And I also learned that one of the main reasons why women don't like to deliver babies in clinics is because they're oftentimes mistreated, or the providers who would attend in clinics, they didn't speak the language. They didn't speak Quiche or any of the other languages that are spoken in this area. And they felt that it was much better to be in the hands at home with somebody who you trust, that allows you to give birth in the position that is better for you and that takes the time. It doesn't matter if it takes 3 hours or it takes 2 days. The traditional birth attendant is going to be with you. And so one of the things that our project tried to do was to link traditional birth attendants with the clinic. And so we did a sensitization process in which we would approach the clinics and say, traditional birth attendants are your friends. They are not your enemies, because I think oftentimes what would happen in clinics is this conception that traditional birth attendants were either ignorant or they would complicate the deliveries and they would make their job harder. And so we try to soften that and serve as the link. So we worked with birth attendants from Guatemala that had received formal training. And so they were the ones in charge of making all this kind of sensitization, talking to the leads of the clinics and say, why don't we allow the women to accompany with their family or whoever she wants to have in the delivery room. And so little by little, we started making some changes in that front.
And your goal was to reduce life-threatening complications like hemorrhage, eclampsia, newborn distress. And one of the ways that you were teaching about this was through simulation. So when I was a medical student, we had a simulation lab. And I don't know if this is what it was like there, but we would all come into a room. There would be a mannequin, there would be a monitor, there would be a one-way mirror with like somebody controlling behind the mirror. And then we would have to act out a scenario on the mannequin, and the mannequin could make noises and its pupils could dilate and all those things. And then at the end, they would say, end scene, and we would debrief and we would, see if we got the diagnosis or whatever. It's kind of a fun way to learn, obviously. It's, much more hands-on than reading a textbook, and of course, safer than practicing on a real person. Tell us about your simulation education program. Did it involve traditional birth attendants? Did it involve doctors, nurses? And kind of how did you, I think in your story, you said that you helped train and educate like a lot of clinicians on the ground. So tell us about that.
Yeah, absolutely. And that is kind of the gold standard, what you described, to have a mannequin and to have this. The issue is that it's extremely expensive to replicate in developing countries, let alone in indigenous villages, to scale a program like that. Only that mannequin that you were describing, it costs around $60,000, only one. And you would need many of them, as many clinics. And in this case, we visited around 50 clinics. So just the cost is a big barrier. So what Pronto, which is the program that I implemented and we led, what it uses is, instead of having that mannequin, we use an actual person. One of the trainees or myself, I would use all these artifacts and prompts to really immerse the participants into the scenario. Of course, at a low stakes, it felt high stakes for them because unlike what you're describing in medical school that you were doing that, this was the first time. So simulation is not common in many developing countries because of cost barriers. And so we had a fabric placenta, we had baby, and to reenact postpartum hemorrhage, which is one of the most common causes of mortality, we would make fake blood and then load it into an IV when instructed, the woman would open the IV and then deliver all the blood. And so it was not so much to prevent these complications because these complications are going to happen, but to have the providers experience them over and over again so much that when they see them, they're not panicked and they don't have to refer a patient to a 2-hour higher level hospital, but they could feel comfortable to take care of them in their clinic. And the clinics that we were working were second level, meaning that they couldn't perform C-sections, but with the necessary education and management, they could attend all of those complications right there. So we would load a real patient with all these props, and then we will read a scenario. So we have up to 30 scenarios to practice different emergencies. We had preeclampsia, we had postpartum hemorrhage, sepsis, and we even have scenarios that are kind of taboo. We had domestic violence scenarios for providers to immerse them in that situation, to talk about them, and to discuss what you should do. And it was like one of the most beautiful experiences that I've had, even to this day in global health, because first of all, it was like the first time that they were immersed into simulation. Second of all, it was the first time also that they were learning in a way that they're not being told. It was more the themes emerge on their own after seeing the scenario. And you have a facilitator guiding that discussion. It's like, what happened? How did you feel? And it's the very first time that those over 550 birth providers that we trained, over and over again, the common sentiment is like, please, let's keep doing this. This was nothing like as we ever learned before. And they know their communities, they know what's happening. And so another great aspect of this training is not only the clinical aspect of like how to identify a hemorrhage or how to identify a preeclampsia, the symptoms, but also it's like identifying barriers in their own system and how to address them. And sometimes when we would hear things such as, well, but it's like the traditional birth attendant doesn't speak the language, so we don't want her to come here. And we say like, wait a second. But what if that birth attendant is the hand that you need to do a massage while you are loading oxytocin to administer to a woman who is experiencing postpartum hemorrhage? So little by little, we were trying to instill this idea that traditional birth attendants it could be their allies, and trying to break these barriers to make them see how they could be their partners in doing deliveries of women.
Do you have any memories? It sounds like you trained over 500 of these clinicians. Do you have any like particular memories or stories of a time that a simulation went especially well, or I don't know, any like funny mishaps or anything like that?
Yes, I have a good one that is one of my favorite ones, and it was 2 parts of the training. The module 1, we will practice postpartum hemorrhage and then also complications related to baby, such as shoulder dystocia. And then on the module 2, the training also focused on team building and how to communicate during emergencies. So thinking out loud, these things that they were never taught or discussed during their medical training. So we would conduct that training. There was a 2-day training, and then 2 or 3 months later, we would come back with part 2 of the training. And so in one of these rural clinics, and it was a clinic in Rachuja in Guatemala, when we came back for part 2 of the training, they told us that one of the issues that they had identified was that when they needed to refer a patient to another clinic, the people that were driving the ambulance, they couldn't hear them. So what they did was to put like a bell. And so when anybody rang that bell, it's like code blue, like you could hear in a hospital, and everybody knew there's a problem happening, and everybody stop whatever they're doing, like there's an emergency. And so the situation was this, and I typically didn't do after I had demonstrated how to do the patient actress. It was actually a very popular activity to do. A lot of women wanted to do the character, and it was great opportunity also for learning, because providers are typically providers. And so it was an opportunity for them to be a patient. And then they could see, like, did the provider ask your name? Did the provider ever, during the simulation, ever ask you how you're feeling? How did you feel? So it was much better not for me to do it. But in this clinic, it was decided that I was going to do it. It was one of my favorite parts of my job too, to have my fake baby, fake placenta. And in this one, we were practicing preeclampsia. So I didn't have any blood because I arrived to the clinic with a headache, with all these other things, and for them to say, oh, that sounds like eclampsia. And in this case, during the simulation, they actually surprised me because they wanted to demonstrate us that they had now arranged a whole plan, an emergency plan, when they had to transfer a woman. And so that was when I learned that they had a bell. So during the simulation, they rang the bell, and then all the people in the clinic actually showed up, and then they actually transported me. They put me on the ambulance, and I was like, oh, and then they took off. And I'm like, oh my God, how far are they going? Are they really taking me to the next third level clinic? Like, please, like, this is a simulation. You don't need to do the whole thing. And it was really one of my most proudest moments as a professional, when with so little, they accomplished so much. And it didn't cost that much. So that's another thing of global health, that the biggest problems, you don't necessarily need a lot. You need people being able to talk to themselves, and how to communicate. And so I was very proud to see this clinic, how they were able, with a little bit of training and facilitation discussion, how were they able to identify so many barriers.
So you were there in the middle of the jungle with a fake placenta and a fake pregnant belly, and they're loading you into the ambulance. They're ringing the alarm bells, and you're thinking, how far is this going to go? It's just a simulation. And then fast forward some time, and you're actually pregnant. And tell us what happened.
Yeah. Oh, wow. You took me there. That was unexpected too. I thought that we were going to keep talking about Guatemala. Fast forward, now we're in the middle of a pandemic and pregnant with my first child. And my delivery had nothing to do with any of the multiple scenarios that I had practiced. Nothing to do with them. My actual first birth ended up with a C-section, and that's not what I wanted. It was an emergency C-section after 2 grueling days of waiting for something to happen, but nothing really happened. And what was also shocking is afterwards, when I asked the OBGYN what happened, because everything was supposedly to be aligned. Like my water broke and 99% of the labors just start spontaneously after your waters break. Mine didn't. So it was like that 1%. And then they try to initiate labor. And most women with a little bit of Pitocin, they will start dilating. Mine didn't. And a lot of things I was like in this 1% or less of women that was not happening. But more concerning was that I was in this very small percentage of women who develop postpartum preeclampsia. It's considered a rare outcome, although we're now seeing them more, because, well, first of all, like it's like one of these things, like why cannot we understand exactly what causes preeclampsia? And this is one of the biggest unknowns. Like there are some theories, but one of the main killers of pregnant women, we don't have a concrete, solid response of what it happens. But there's some theories that is something mediated by the placenta. But then again, I had delivered that placenta. That placenta was not in my body. 48 hours later, my blood pressure was out of control. So why is it that 2 days later, when supposedly the organ that mediates or produces preeclampsia is producing this high, uncontrollable instability in my blood pressure? Again, like, there's no answer to this. But it was in a situation that I never expected. It was actually quite the opposite. I thought that with all the knowledge, all the experience that I've had practicing, I was going to be able to identify when something was not normal, that I was going to be able to advocate for myself, that I could tell and discuss with a provider. But I was in a complete unexpected situation in which I felt very vulnerable with a lot of fear, intense fear of not knowing. And the other terrifying part of postpartum preeclampsia is that it's different from the high blood pressure that is experienced at a later age. Because for those cases, you have your blood pressure medication and come back in 3 months. Goodbye. This one, because I don't know if it's because they don't know exactly what causes it, but there's no one single thing that you have to do. First, you have to find out the right titration, the right concentration, and sometimes the right combo. And in my case was all of that. And it took a while to find the right dosage. And I felt like I started motherhood with a lot of terror, because what it was supposed to be an in and out situation, 48 hours, it ended up 2 weeks in a hospital. And after that, I felt very unprepared on how to take care of an infant, when I felt pretty traumatized by everything that what happened in the hospital. Even though I have to say, it had nothing to do with the care. I actually received exceptional care. It's more on these situations, nobody can tell you not fear death, like don't fear this because it's going to happen. And with this one, what was causing me a lot of anxiety was not knowing when they were going to get it right. And it's also one of these situations in which I knew that was also like one of the most common causes of maternal mortality. But again, I also had to tell myself, yeah, but this happens when women not necessarily measure. Like I was already hooked up with all the things in the hospital, but it's still in my brain. It's like, what if they miss something? What if they come too late? What if I have a stroke? And, like all of these things start spiraling in your head.
Yeah, as a physician myself, I know that I've had experiences where I've gone to the doctor and, sometimes they'll be like, oh, well, you know this because you're a doctor. And I just want to be treated like a normal person at the doctor. Sometimes I don't even tell them I'm a doctor.
Yeah.
I remember one time I went to a party with my husband in Washington, D.C., which is where he was living at the time. And it was late. People were kind of drunk. And they decided it would be a good idea to go up on the roof. And it was an unfinished roof. And we got up on the roof And I was kind of already in a bad mood. Like I wanted to leave the party. I didn't really want to go on the roof. I actually just wanted to go home. And my husband said, let's just go on the roof. Let's have a drink and then we'll go home. So I sort of begrudgingly crawl up this ladder. I get on the roof. People are hanging out. It's like a dark black roof cover, like it's unfinished. And it was summertime and I was wearing flip-flops. And I started walking across the roof and then I feel something go into my foot.
Ooh.
And it was a giant rusty nail, went all the way through my flip-flop and into my foot.
Ouch. Ow.
And I was already in a bad mood. And my husband had to pull it out of my foot. And then, I had to climb down the ladder and go into the bathroom and rinse it off. And I remember this guy came into the bathroom and he said, "Are you okay?" And I said, "Yeah, I think so. I'm fine." And he was like, "Well, I'm an Army medic and I'm going to take a look at your foot." And I did not want to tell him I was a physician. And I just wanted to surrender to this Army medic. And so he got on his hands and knees and he held my foot and he said, "Move your toes like this and move your foot like this." And it just felt so good to be cared for. And it just really struck me when you were saying, even as somebody who is a global expert in preventing and educating around, bad outcomes related to childbirth, somebody who's literally simulated it numerous times, that when it's you and when it's real, it just feels so different. And in a way, the expertise, it kind of just goes out the window on some level.
Absolutely. Absolutely. I felt so vulnerable. And because it's one thing to be teaching and to reenact the scenarios when your life is in the hands of others. And in the particular case of preeclampsia, I said they also inject you with magnesium sulfate. And I remember in the trainings during the debrief asking, because this is something that my own boss told me, ask about if anybody in the audience, in your trainees, have felt what it feels, magnesium sulfate. Because it's this burning sensation. But then back then, I hadn't experienced it, right? I was making space to have that discussion, but almost like somebody telling me that that's how it feels, and to making sure that participants understood that it's a very unpleasant feeling. But then experiencing myself, magnesium sulfate is like burning inside out. And it takes a while for magnesium, because they had the drug on the body for a few days because they were trying to prevent a stroke. So it was almost like a dose of humility for me.
Totally.
For me, it was you're not only talking about issues that happen to other women. This happened to me. I'm in the best healthcare system in the world. I had exceptional care. The kindest nurses and physicians that would talk to me, almost to your point, what you were saying, almost tell me too much. And I'm I don't want to know that much, because it's I know that usually knowledge is power, but in this case, knowledge is causing anxiety. And I still felt intense fear and powerless. I depend on these people knowing what to do. And ultimately they did. But I still, that's something that stayed with me. That in many cases, I was lucky that I had all these access to all these resources. But in my privileged position, that was not the case for another women. But I still felt that something that unites me and I can relate is to that fear that you feel.
Did it make you think differently about your work in Guatemala after going through that experience?
Absolutely. Yes. Yeah. It made me, well, like I said, it was a humility check to think that this is not something that happens to other people. It can happen to anybody. And from now on, I'm going to give baby showers. I'm going to give blood pressure cuffs because I know so that's number one cause of deaths in the US. And I was lucky that I knew that if I felt a little bit off, I had to check my blood pressure. But if I didn't know that, I would have felt like, especially after your first pregnancy, you don't know how you're supposed to feel. Like, especially after a long birth, I could have attributed all that to just the lack of sleep, or I just had major abdominal surgery. And so I was lucky I had my blood pressure and I checked it, and it was a very scary reading. And I immediately called and I was admitted and I was taken care of. But that's not the case for many women. And another reason why I changed the way that I think about my job is because this is not only in rural Guatemala, and actually in some cases they're more protected from these rare outcomes because the demographics and how things are, like women are having children at a later age, and these outcomes are more common at a later age. So I feel that, well, these are topics that we need to talk more broadly. Not only in Guatemala, but there's also disparities here, and we have to talk about them here more than what's the first outfit that your baby's going to wear in the hospital.
Well, it's been such a pleasure speaking with you and learning about your work in public health and about your personal story. Is there anything you want to share with our audience before we end? Maybe somebody who's interested in getting involved in public health or global health or women's health or anything like that? Any last thoughts?
Yeah, these are topics that are more important to talk about than ever before, because right now the women have, instead of having greater access, and I'm talking about not Guatemala, I'm talking about women in the US. Shocking to say this, but instead of having more access to information or to resources that can prevent these complications, we actually have less. And I would encourage all women, and that's why I was so excited to do this podcast, is to share their experiences. So it's not something that when it happens is when you learn about them. And so just know that if you want to be involved in health, you don't have to be a doctor. There are many, many things you can do that are not direct care with a patient, like global and public health. You take care of health of groups of people. And that's another area where we need more support than ever before, as the field is hurting at the moment.
Well, it's been wonderful to speak with you. This has been Solange Madriz. Solange, keep up the great work. And thanks so much for coming on the show.
Thank you, Emily. It was a pleasure. Thank you for making me feel so relaxed to share my experience.
This episode of The Nocturnist was produced by me and producer and head of story development, Molly Rose Williams. Our executive producer is Allie Block, and Ashley Pettit is our program director. Original theme music was composed by Yosef Monroe, with additional music from Blue Dot Sessions. The Nocturnist is made possible by listeners like you. If you enjoy what you hear and you want to support our work, consider subscribing to The Nocturnist Plus. You'll get access to The Nocturnist After Hours, our monthly bonus series featuring original conversations from our team, along with merch discounts and a full archive of episodes all in one place. Subscriptions start at just $10 a month. Learn more at thenocturnist.org/plus or through the link in the description. Thank you for listening and being part of this community. Until next time, I'm your host, Emily Silverman.